We'll begin here by demonstrating the landmarks and the portals. You can see that we've marked the anterior superior iliac spine and a line extending distally from it. We never want to go medial to that line in order to protect the femoral neurovascular bundle. Here we've marked the greater trochanter, and we've marked an anterolateral portal and a distolateral accessory portal. Usually these portals are used for intra-articular procedures as well, so we can reuse them when we go to the peritrochanteric compartment in cases where we are addressing both intra-articular and peritrochanteric pathologies in the same case. So we'll make these incisions, and we'll begin by introducing the scope into the peritrochanteric compartment through the distolateral accessory portal. Normally I'll perform this introduction under fluoroscopy, and I will aim for the vastus ridge, and the goal is to place this trocar in between the IT band and the vastus ridge, the bone of the greater trochanter. So we can sweep once we're there and get a feel that we're in between the IT band and vastus ridge, and then we introduce our scope. This is a 70-degree arthroscope. Okay, so the first thing that we'd like to see ideally is the longitudinal fibers of the vastus lateralis. If we see the vastus lateralis, then we know that we're in roughly the right spot. So we can do a little bit of sweeping here in this tissue and in the bursal tissue in order to find our way to the vastus lateralis, and then we'll bring the shaver into the same space in order to meet ourselves, and we can shave the bursa. We'll always keep the blades facing toward the IT band so that they're facing away from the gluteus medius. Here we begin to see the gluteus medius muscle fibers, not as red in a cadaver as they might be in a living person, but you can clearly identify them nonetheless. And down here we're looking for the vastus lateralis fibers, which will be longitudinal, shiny white fibers. We've cleared out the trochanteric bursa. You're looking at the gluteus medius muscle here. This is the greater trochanter. Down here is the the vastus lateralis fascia. This is vastus lateralis fascia. This here is the gluteus maximus tendon, which inserts posterior to the vastus lateralis onto the femur down here. I'll give you a different perspective on this as well if I invert the view. Here you can see gluteus maximus. That's all gluteus maximus on the right-hand side of the screen, coming down there and inserting posterior to the vastus lateralis. This is all vastus lateralis on the left-hand side of the screen. So coming back to the gluteus medius, this patient actually has a partial undersurface tear of the abductor. We've now created the distolateral accessory portal here where we've put the scope, an anterolateral portal with a trimmet cannula, and a far posterolateral portal with a trimmet cannula. So next, we've evaluated the tendon and felt that there's a partial undersurface tear of the abductor, and you can see how mobile it is here. So next we want to perform a marrow stimulation, which is effectively the same as a microfracture, but we've called this a trochanteric micropuncture. So we'll come right through the tendon to the bone. So through this approach in a transtendinous fashion, we're going to perform marrow stimulation with the trochanteric micropuncture. So next we're going to place our anchors. The first anchor we'll place posteriorly. Bring the sleeve to the bone, and then we're going to want to impact the punch first. This is a posterior anchor, so we're in the posterior part of the lateral facet of the gluteus medius insertion. And we'll place an anchor here. So going through a drill guide for this percutaneous, for a percutaneous approach can be very useful as well. So now we'll screw in the 3/9 knotless corkscrew anchor to the laser line. You want to see that the laser line here comes to the guide. That's how you know that you're down, because we're going through the tendon here, so you can't see the bone. You can feel it though with the end of the guide. So now we've got one anchor in, and we test that and make sure we got good fixation. Take the punch again, and now we're going to place an anchor in the more anterior part of the greater trochanter. So now we're going to place this anchor. So once again, we punch. Make sure that laser line is up to the guide, and then we introduce our anchor. Push it in so that the threads engage, and then twist to insert it the rest of the way until the laser line. Okay, we'll test that as well. So now you can see our two anchors are placed, and now what we're going to do is we're going to crisscross the repair sutures. So I take this repair suture out the anterior. So I'll take the anterior repair suture here, and we'll bring it down, and then I'll retrieve that through the posterior cannula. All right, so now to look at our construct, you can see that we've got the sutures crisscrossed, the repair sutures crisscrossed, and now we're going to do the shuttling. I want to pull tension on the repair stitch and both of the shuttle sutures, and make sure there's no slack in the system. And then we'll take the loop here. You can see the loop, and I'll pass the repair suture through the loop, like so. Pull it through, and I want white to overlap with white and not overlap with the stripe. White overlaps the white, but does not overlap the stripe. Okay, so I shuttled that through. Now I'm going to do the same for the posterior portal. So now again, we do the same thing on the posterior portal. Take the slack out of the system, pass the loop, pass the repair suture through the loop. White overlaps the entire white, but does not overlap the part with the stripe. And then we shuttle it through, like so. Okay, so now we grab our two ends of the repair sutures. You see we have two loops, and we can pull on both. And this will cinch down our suture staple, like so. So that's it. Now we've completed the suture staple. You can see the two strands of sutures as each anchor is daisy chained to the other, A to B, B to A. And then we're going to push this cutter. This is a cutter pusher. So we push this in to the joint, to the peritrochanteric space, and then push on the end, and that cuts it. And then we'll do the same for the other one. So the more extensive the tear, the more pairs you may use. If this delamination extends a good part of the way down the lateral facet, you probably want to use 2 pairs.